You're listening to Admitting Diagnosis, the Journal Watch podcast for the week ending September 5th. I'm Joe Elia. We offer a brief roundup of the week's essential medical news, the terribly important stuff, plus an interview. This week we talk with Dr. Anne Schuchat of the Centers for Disease Control about childhood immunization levels. If you'd like to leave us a comment, I think you should, call 617-440-4374. Links for everything we discuss here are available at podcasts.jwatch.org. Okay, here are the week's essential medical stories very briefly. Exercise and cognitive impairment, Vytorin's risks and efficacy, and omega-3 versus rosuvastatin and heart failure. Now for some details. Older people with memory impairment, but not Alzheimer's disease, were randomized to either usual supportive care or to an exercise program for 6 months. At 18-month follow-up, the exercisers had slightly higher cognition scores, plus they exercised on average 2 hours more per week than the controls. An editorialist in JAMA says that exercise's minimal costs and minimal adverse effects make it an attractive option in an aging society. Next, Vytorin. The combination of simvastatin and ezetimibe, marketed as Vytorin, didn't do any better than placebo in patients with aortic stenosis, although it did substantially lower LDL levels. After a 4-year follow-up, patients on Vytorin and those on placebo were at about the same risk for aortic valve replacement or cardiovascular events. The researchers noted a surprise increase in cancer incidence on Vytorin, which, when analyzed in pooled data from other studies from the drug's manufacturer, diminished. Editorial writers in the New England Journal of Medicine aren't so sure, however. And writing in Journal Watch Cardiology, Harlan Krumholz cautions that clinicians and patients on Vytorin should be aware of the uncertainty. And finally this week, omega-3 versus rosuvastatin. 2 Lancet studies encompassing some 7,000 patients with heart failure found that those randomized to receive daily omega-3 fatty acids had a small but significant reduction over placebo in all-cause mortality or hospital admissions for cardiovascular diseases. This effect was found over a 4-year follow-up, during which rosuvastatin recipients didn't show a change in their outcomes versus placebo. And here is the Journal Watch interview. This week, MMWR published a report on vaccine coverage in children ranging from 19 months to about 3 years of age. The report details the findings of the National Immunization Survey for 2007. The survey established that more than 90% of children in that age group had received at least the routinely recommended vaccines, and almost 80% had received the full series, showing steady progress. We've asked Dr. Anne Schuchat, a member of MMWR's editorial board and director of CDC's National Center for Immunization and Respiratory Diseases, to discuss the implications of all this. Welcome, Dr. Schuchat, and thank you for taking the time today.
It's my pleasure.
So this is good news. Now, according to your calculations, this cohort of children have avoided some 14 million illnesses and perhaps 33,000 deaths with these immunizations.
You know, that's right. Immunizations save lives and keep children healthy and safe, and they also protect our communities. And the survey results that we've just released confirm that we're retaining the high immunization levels that we've enjoyed for the past few years in toddler-age children. Our results this year suggest 77.4% of U.S. children have received the full series of vaccines recommended by age 36 months. And those vaccines include the series of diphtheria, tetanus, and acellular pertussis, polio vaccine, MMR vaccine, Haemophilus influenza B vaccine, hepatitis B vaccine, and the varicella or chickenpox vaccine. So quite a few vaccines that providers are keeping up with and that parents are also making sure their children get.
Well, that's a lot of shots, isn't it, for people to be administering and to keep track of?
It's gotten more complicated, and so providers and parents do have challenges. We think that immunization information systems or registries can make it easier for parents and providers to make sure that children are up to date. And there are other decision tools out there that are available. But it's a big job being a parent or being a provider, and what we'd like to do is make sure we can get good information out there to help both pediatricians, family physicians, and parents keep up with the jobs they have.
Okay. Are there tools, office-based tools, that clinicians could use to help track these vaccinations? Does the CDC have any links it could offer in this regard?
Yes, absolutely. There's something called the immunization scheduler that's available through our website. It's an interactive tool where parents can actually plug in their children's immunization histories and find out which shots the child is due for and when to make the appointments. There are similarly, physicians' offices can use this. Many providers are using immunization information systems or registries, which often have those decision analysis tools as well to help sort out if this is what the child has already gotten, what is it time for in this next visit.
And what's that website? What's the URL? Do you have it off the top of your head?
Yes, the CDC's immunization scheduler can be accessed through our vaccine website, which is www.cdc.gov/vaccines. And you can see immunization scheduler as one of the choices on that page. Okay,
so www.cdc.gov/vaccines, plural.
Right,
okay.
Plural, correct.
Good. All right. Now, in the report in MMWR, some states are doing very well. Others don't seem to be. Maryland, for instance, looks, immunologically quite safe for babies, without necessarily naming the laggards. What do you think is preventing them from reaching Maryland levels?
We do see quite a bit of range state to state, and it takes a lot to achieve high coverage rates and then maintain them. We think that there are some best practices out there that involve pediatric office or family physician office practices, including using reminder and recall systems. Reminders are letting parents know that it's time to schedule an appointment, and recall means calling people in when they're overdue for an appointment. We also know that increasing access can help, and having night clinics or weekend hours can really help some of parents who just can't get off work to bring the child in during the routine business day. That increasing access can really help. We also know that immunization registries or information systems can help because there's just quite a lot of vaccines out there and a lot of children to track, and these technology solutions can really help us stay on top of things. So those are a few of the tools that are used more broadly in states that are doing a bit better. The other thing is the financing situation. There's something called the Vaccines for Children program, which provides free vaccines for children who are uninsured, Medicaid eligible, American Indian, or Alaska Native, or who are underinsured but seeking care at a federally qualified health center. And that can really overcome the cost barrier for the poorer children in the country. Some states also are able to identify additional state resources to help make sure that vaccines are accessible.
And you mentioned the Alaska Natives and the American Indian rates and programs. Those rates now are pretty comparable, in some cases better than the rest of the country, aren't they?
Yeah, we're excited that this year's survey suggests there's been a major improvement in immunization coverage among American Indian and Alaska Native children, with significant increases in chickenpox vaccine and in the fourth dose of pneumococcal conjugate vaccine, as well as in the MMR vaccine. We just saw big jumps in those coverage estimates from this special population. And it'll be important for us to keep looking at trends and make sure that these persist, because the numbers are fairly small. But I think that it's very good news. At this point, for several of the vaccines, American Indians and Alaska Native children have the highest rates of vaccination.
Do you know what they're doing in Maryland, by the way? Has anyone there done a study to look at some of the things that Maryland's doing to keep their rates up so high, or is it just because they're also close to the NIH?
Well, we've actually visited a number of the top performing states to get a better idea of these best practices. And there's a mix of factors. We find that immunization champions at the state or local level can make a big difference, leading pediatricians or a leading public health expert who really get the word out to peers and parents can make a big difference. Many states, including Maryland, will also have immunization coalitions that really bring partner groups together, health plans, pharmacist groups, private pediatric offices, nonprofit organizations and others together to really brainstorm about how to reach more people. I've met with coalitions in a few states, and people like firefighters are involved in some of the states' coalitions just to try to understand how do we reach children who are hard to reach and how do we get the benefits of immunization and good information out to the people who need them.
It sounds like what the practicing clinician can do is get his or her hands on that scheduling software from you all, and maybe integrate that into their practice to at least give them a better sense of tracking some of these kids.
Yes, and I think we really encourage practitioners to be in touch with their health departments and learn more about immunization information systems or registries if they're not already plugged in. In a number of states, there are pretty good registry programs that can come out and visit the office and help get the provider connected. And these are web-based tools that a provider can check a record and essentially find out about immunizations that have occurred in other places. It can be challenging when children transfer from one office to another office and you don't have all the history, but we really think you can save on having to revaccinate children by getting the past history together.
There is some reluctance on the part of parents to vaccinate because of perceived dangers of autism, and this week, there was a new study from the Public Library of Science showing that the MMR vaccine isn't associated with autism. Do you think that some of the variations that you see geographically might have to do with a cultural skepticism about trusting the government? And what do you think of that PLOS study?
That recent study was helpful in being one more study to fail to find a link between autism and MMR. And in fact, it was not able to reproduce the results of the original study that raised the hypothesis. So it was good news in terms of vaccines not being linked with autism. Many parents still have questions, and I think it's important for parents to get answers to their questions. We'd like them to be able to have good conversations with their doctors or healthcare providers, and we also want to provide good information ourselves through the government sites. But it's so important for parents to feel comfortable about the decisions they're making for their children because no parent wants their child to be harmed. These days, looking at all of the information that's been amassed, experts, the Institute of Medicine, the American Academy of Pediatrics, and the CDC have all reviewed the situation and do not find a link between vaccines and autism. Has every single hypothesis been looked at? Well, no, but there have been huge numbers of studies at this point that have not found a link. But it's important for parents to get those questions answered. In terms of our study data, we don't see, at this point, huge variation by state that can be explained by sort of cultural concerns. One variation that we see is that we still do have a significant gap between children living in poverty and children who are better off. We've narrowed the gap, but we haven't eliminated it. So that's something that we do take seriously and want to work on. In terms of communities where people may not feel strongly about vaccination, we're trying to get a better handle on that with some parental acceptance surveys, trying to understand what are the concerns that parents have and what questions do they have, how can we better meet the needs that they have. One thing that's important to note is that we're enjoying high immunization coverage as a nation, and in most states the data are pretty good, but we're still seeing measles cases and outbreaks of measles more than ever in the past 12 years.
Are there resources available at the CDC for parents who have questions such as, is getting my child vaccinated putting it at risk for autism?
Parents do have questions, and we want to make sure their questions are answered. The CDC posts information on vaccines, including the benefits and the risks, on our website, www.cdc.gov/vaccines. There's a whole section of information for parents on that site, and we encourage people to read more and learn about these products, as well as to talk to their providers and get their own questions answered.
Okay, great. Thank you so much, Dr. Anne Schuchat, for joining us today.
My pleasure.
Finally this week, I want to thank the many people who agreed to be interviewed for the months that this podcast was in that stage of development, politely referred to as prototype. There are other names for the process. Well, we've included all those prototypical interviews on the website, podcasts.jwatch.org, and they're worth listening to. After all, it was the interviewer who was doing all the learning. Let us know what you think. As always, if you'd like to talk about any of this or anything else, call 617-440-4374. Just leave your name and number so I can get back to you and get your permission to put your comments on the podcast. Links for all stories are available at podcasts.jwatch.org. Join us next week, won't you? Thank you for listening. For the Journal Watch podcast, I'm Joe Elia.